next up is Dr. A.J. Malhotra. Dr. Malhotra is an acute care surgeon and division chief of acute care surgery at the University of Vermont Medical Center, where he's a professor of surgery. A.J. today is going to talk to us about VTE as a hospital quality indicator, a topic near and dear to my heart. I'm dying to hear this talk.
Dr. Howard, really a pleasure to be here, and thank you for the invitation, Todd and Elliot. So, as you all know, over the past 20, 30 years, another area of development has been quality. How am I sure that if I go to this hospital, I'm getting the best of care? And this has led directly to a search for indicators that if a hospital meets these thresholds or criteria, then the hospital in general is a better functioning hospital, and you can be assured that the care you get is there. And VTE on the surface, because it universally affects every patient who is admitted to the hospital, is something that should be considered. Sure, this could be a good quality indicator. So in the next half an hour or so, I'll show you sort of the pros and cons of where this is and what are the intricacies involved. So instead of belaboring these, we'll just accept these as facts that VTE affects about 600,000 people every year with close to 100,000 dying annually. The numbers are different where you look, but this is sort of a general number. Some are even higher. Up to 30% of the VTEs will go on to develop post-phlebitic syndrome, which is a terrible way to live. People really suffer, adds cost and to the healthcare system. And finally, not very common, but about 5% of the PEs will go on to develop chronic pulmonary hypertension, which is extremely crippling to the patient. Now, about 50% of the VTEs seen in the country occur in the peri-hospitalization period within 90 days of hospitalization or surgery. And as we are discussing here, majority of these are preventable with appropriate prophylaxis. So can VTE prophylaxis and or event rates serve as a hospital quality metric? So looking at the literature, I was surprised there's no good definition of what exactly should be an ideal quality metric. One of the better ones I found was that some characteristics that a metric should meet. Number one, it should be a meaningful measure, basically applied to a broad range of patients rather than just, because when you're talking about quality, it's not specifically to some patients, but it's a meaningful measure. Second, it directly impacts outcomes. And if you meet that metric, the patients will do better. Three, it has minimal potential for unintended consequences, and this will come up later on because some of these metrics, to try to meet them, lead on to weird things that start to happen, and you scratch your head and say, we never thought this will happen. So there are possibilities, so it should be minimal to have unintended consequences. Not gameable. We are all familiar with pay-for performance, and these quality metrics play a big role in it. And people do try to game them, and it is possible to game a lot of them. So an ideal metric should not be gameable. It should be objective. There should not be a subjective element to it that I think and you think, but everybody thinks the same. And again, the burden of collection of that metric should not be excessive. That it's just difficult to quantify that. So it's either consistently collected or easily collectible. And finally, there is an element of risk adjustment. It allows some risk adjustment based on patient characteristics and the acuity of the condition being treated. This is the best one I could find, which I thought, and if you think about it, VTE prophylaxis or VTE event rate checks a lot of these boxes. So on the surface, it is a good measure to look at it. And actually, people who do pay for performance and the quality folks who look at hospitals, a bunch of them in the USA, but also in other countries, have adopted VTE as a quality metric, and VTA-related quality metrics are often utilized in pay-for-performance plans. So now it gets interesting. In a USC study, you're looking at 33 U.S. academic medical centers. What they found was that rates of prophylaxis are extremely variable. You can see the dots represent appropriate prophylaxis in medical patients on the x-axis and surgical patients on the y-axis, and there is no correlation anywhere. And this was interesting that medical patients, when they looked at it, about 59% with a range of 26 to 100% received appropriate prophylaxis, and the surgeons did not do as well, 39% on the average, and with a range of 16 to 70%. So rates of prophylaxis are extremely variable across hospitals and actually even within hospitals, depending on the service, as was being discussed between the various ICUs. Now, something that somebody just triggered on, I think it was Dr. Joseph, effective VTE prophylaxis is a multi-step process. First, there should be an individualized VTE risk assessment for every patient who is admitted. Second, based on that risk assessment, a prescription has to be written for appropriate prophylaxis. Third, that appropriate prophylaxis has to be administered. And I think this is often neglected. The patient has to accept that. How many times have you seen a chart, patient refused? And I think Dr. Hout has done a lot of work on it as to how we can change those practices. So there are multiple places where this thing can fall apart. And it also leads to what component of this should be considered a quality metric, which element should be targeted, because unless all of them are present, effective VTE prophylaxis will not happen. There is wide variation among agencies. This is coming from a nice compiled paper of Dr. Hout, where various agencies are looking at different parts of this. So like the UK and Australian one, as long as there is a risk assessment documented, we'll give you a pass on that. Some go to multiple steps, like the Australian one, also required a prescription being written. Go to the American ones, they demand a prescription, and some of them actually look for at least one dose was administered. So that's what the partial means, is that they don't care across the whole continuum of the patient's admission. If one dose was admitted, they'll check that box for you. But will that truly impact patient outcome? The second question that comes up is process versus outcome. VTE prophylaxis rates measures a process. There's an assumption being made that if you improve the process, there will be improved outcomes. Probably true, but if you look at the current definition of quality or value of care, process doesn't come into it. What you're looking for is outcomes over cost, so a cost-effective way of delivering the care. So that leads to the question, instead of the process, why don't we measure the VTE rates as a quality metric? The devil very often is in the detail. There are unintended consequences of looking at the VTE rates themselves, because VTE is one of those classic conditions. The more you look, the more you find. And I agree with Dr. Gates that some of it is not significant, but if you keep on looking, like for screening, and I'll come to screening in a second, the more you look, the more you will find. And this incentivizes hospitals to find an appropriate treatment VTE, especially if they're going to get a ding that you are a poor quality hospital, and especially if it hurts the bottom line that you will lose the incentives of being a high quality hospital. Then there's a whole question of surveillance. So surveillance may not be directly related to this talk, but I think it has been brought up in the previous two lectures, so just spend a couple of minutes on it. To surveil or not to surveil is the question, and there are multiple articles that have been written over the last 20 years looking at them. I will submit majority are low volume in terms of patient numbers, majority are retrospective, so it's difficult to draw a firm conclusion whether surveillance is worthwhile or not. And this led the CDC to have a similar conference as we are sitting on, a CDC consensus conference on surveillance. And what they said was, By improving the utilization of proven effective preventative measures, it is critical in reducing the rate of VTE. But they did go on to say systemic surveillance is critical to provide data on the prevalence and annual incidence of VTE in the U.S. Systemic surveillance will be important to enhance prevention efforts, and they suggested the CDC should make a second group conference for consensus regarding the role of surveillance in future VTE. So one of the studies which came from my shop, it was a pre and post type of study. What we found was, as you can imagine, the more you look for it, the more you find. So when we started doing surveillance only in the ICU, so every patient who got admitted in the ICU within 48 hours received one duplex ultrasound, and they continued for that period of they were in the ICU twice weekly. But here's what surprised us, and this is a retrospective study. Here's what surprised us, is that while the DVT rate went up, the PE rate halved. And surveillance was, after controlling for other factors responsible for, which are associated with high rates of VTE, surveillance was associated with a higher rate of DVT detection and maybe a lower rate of PE incidence. So it was an independent predictor by logistic regression. The cost comes up. So we did a cost analysis, and you can see there, in terms of DALI saved or QALY saved, DVT surveillance is about $20,000 to $50,000 per QALY, and it compares very, very favorably. So many other interventions we constantly accept: use of statins, warfarin for stroke prophylaxis, implantable defibrillator, lung transplantation. So the single study, retrospective, not controlled. So, but it's an interesting signal that there may be something to surveillance which we could look at in a more advanced study. The impact of surveillance bias, what I was mentioning, if you surveil patients in your hospital, your DVT rates will go up. That will give you a ding from the agencies, and you may lose some money. So this has been looked at as to what is the impact of surveillance bias. There was a systemic review of 10 VTE studies, and 9 of the 10 showed that there was a positive correlation of VTE with imaging intensity. Hospitals with higher quality scores had higher VTE prophylaxis rates, but interestingly, worse risk-adjusted VTE rates. So there is more to this than meets the eye. Increased hospital VTE rates were associated with increasing imaging rates. Surveillance bias limits the usefulness of VTE quality indicators for hospitals working to improve quality. Then one of the studies actually looked at patient safety indicator number 90. Patient safety indicator number 90, one of the components is a VTE rate. It's widely used in federal pay-for-performance programs. And they looked at 3,203 hospitals across the nation, and they calculated the PSI with and without including the VTE number in it. And what they found was 17% of the hospitals improved in their performance if VTE rates were taken out. 21% worsened, and 62% actually remained unchanged. And the hospitals that improved were the characteristics of those hospitals. They were in general larger hospitals, academic medical centers that had more technology, again, maybe more surveillance, maybe more investigations, and they often treated the sicker patients. So the VTE rate as a quality metric analyzes larger academic centers with more sick patients. In summary, VTE is a high societal burden. Most VTE occurs during or post-hospitalization or in the perioperative period. Majority of these peri-hospitalization or perioperative VTE is actually preventable with appropriate prophylaxis. VTE prophylaxis is highly variable across the country, between hospitals, and even within the hospital. VTE prophylaxis and VTE event rates can serve as an important hospital quality metrics, but there are certain caveats. The role of surveillance is unclear. Utilizing VTE rates as a metric may unfairly penalize large academic medical centers and teaching hospitals. So there's more work to be done if we should use this or not, and if we do use it, how to use it. Proving Vte profile access may have a halo effect. And this has not been studied, but it is to achieve effective profile access as we went through the multi-step process. That could have a halo effect, because if the same principles can apply to other things that you are trying to prevent, if the hospital can truly crack the nut of being able to do the 4 steps in sequence and achieve it, those principles can then be applied to other areas and the quality goes up. It's interesting that there is no study to look at that, but that may be a study worth doing, is that in general, if you have a high profile access rate, is the hospital has improved outcomes in other areas not related to VTE.
AJ, that was great. So I'm going to take the privilege of the mic and ask the first question, which is, you told us all these potential problems. If you could snap your fingers today and tell us what's the best way to measure quality as it relates to VTE, what would you propose to us?
So probably we have a combination of the process measures and the actual events, because individually they have problems, but maybe in a combined way, as you have written about, that could serve as a good way to look at it. But again, I do feel that work should be done before we accept it, that this combination measure is the way to go.
Seems like surveillance is the big issue here, as you showed in these quality metrics. And I think it goes back to some of the comments Dr. Geertz made earlier about, they don't look because the asymptomatic small DVTs, they don't want to find them and they may not matter. In that talk, he showed a paper from my center dating back to the 90s by Shackford and Hoyt, where we've been surveilling, for the past 3-4 decades, whatever it is. We still do it because Dr. Hoyt said so. But I guess, as somebody who thinks a lot about VTE and somebody, who wants to do the right thing, I'm a little uncomfortable knowing that these DVTs exist and then not looking for them, right? They're happening anyway, so why wouldn't I want to know about them, know the extent of them, and know if I should treat them? So how do we reconcile that, where I think it might be a good thing for the patient to know if they have a DVT or not, but it would certainly make my hospital PSI 90 and the number of emails I get from the, vice chair of quality would go down significantly. So how do we manage that?
Right. So the question may be whether these are significant and whether they will lead to future problems. So while we can say that we would like to know, but would there be a problem if they are missed? Do we truly know the natural history of these, say, below the popliteal DVTs? What happens to them? So again, I know this conference is about profile access, but a very interesting question. And now we don't have to do the venography, and the duplex sonography is very good, and it may be a reasonable thing to find out the natural history, and that may help answer the question as to whether we should go looking for them or not. The quality part, how it may reflect, will need more thought. Is it possible to come up with a composite number that takes into account the increased detection? I don't know, but again, quality metrics should be relatively simple and don't make it complex. But I think the natural history is a question that's not answered yet.
The question's pretty straightforward, and it's very similar, which is that even though the quality metric is designed to be simple, dichotomous outcome variable for VTE is not useful. Really what I think we're getting at, right? Because popliteal DVT almost never becomes, but it goes into all of these quality metrics for the hospital and immediately gets picked up. And in fact, once it does, penalized for it. Problem. So I think on the quality side, perhaps we need to not overly simplify the variable for it. Any comment about how one might facilitate change like that in a large medical center?
One of the characteristics is it should be risk adjustable. So again, it does make it more complicated, but sometimes oversimplification is bad. But where is that boundary is can be a difficult question to answer. But you're right. A dichotomous variable is either yes or a no, and if it is a yes, you get penalized. That's a huge disincentive for me getting to a yes, even if it helps my patient. Maybe risk adjustment could be included in it rather than making this completely. Sure. So when I broke my ankle, I had to self-administer. I can tell you, it ain't a pleasant process. First, you stick the needle in, and you're all bruised over. So patients do object to it, and again, Dr. Hout has done a lot of work on it as to how we can possibly overcome that barrier. Yes, it stings and it makes you black and blue, but in the end, it's good for you. And the whole project was that when patients refuse, maybe with added education, that barrier can be overcome. And that is one of the things I think in the future is to how to implement it. But you're absolutely correct. Patients nowadays, and for good reason, they are their own advocates. They know their rights much better than they used to. They know they can say no. So I think it throws the challenge back at us as to how we educate them and make them understand that saying no may be harming yourself. But it is an important one. Patient acceptance of treatment will be a challenge in the future, not just in this area.
Question over here.
Hey, AJ, great talk. Do you think we're ever going to get to something other than a Takados variable? To follow up on that question before, I really struggle with the VTE that happened adjacent to a fracture in patients that actually got appropriate prophylaxis all the way through. That's a very different entity than somebody who missed many doses or we started late. Do you think we're ever going to be able to get to a risk adjustment because a yes, no at that PSI 90 doesn't benefit a lot of us?
Right. I don't know, but I think the reason we presented this was that what seems to be straightforward has a lot of nuance with its pros and cons. So I would go back and say, is VTE prophylaxis a good quality metric? I don't know. With these nuances involved, and maybe in the absence of simplicity, getting more and more complicated, we say no, it's not a good quality indicator. We won't use it, either the prophylaxis process or the event rate. But I don't know where it will go.
So with no more hands raised, thank you very much.